So we have Dr. Gershon Golan, who's coming in from Israel, so we thank him for traveling long distance to be with us. He's a professor of pharmaceutics at Hebrew University, has a long career in drug delivery and drug release, and dating from 1986, I think the original, Troublemakers, which was Elazar Edelman, if I recall well, Cam Leon, and you. I guess this was the trio working with Bob early on to push this. So we have actually a good, it's a privilege to have you here also to give us a little bit of a sense, outside the U.S., how you're able to, push the nanomedicine field. Thank you so much.
So this is the laser, and the arrow here is the arrow that advances light.
Thank you very much, Zai. Thank you for inviting me to this talk. Actually, it's the first time that I'm here in Mount Sinai. And, I've been several times in New York, but it's the first time. But more than that, it's the first time that I know that I'm in Mount Sinai because there is a sign outside. Last time, it was 35 years ago, I was in what's so-called Mount Sinai in the Sinai Desert in the peninsula between Israel and Egypt. So archaeologists and historians are saying this is Mount Sinai and this is Mount Sinai and Santa Catarina is Mount Sinai. And this is the first time that I'm sure where am I. And thank you for that, Zai.
Thank you.
This is a great thing.
Sometimes I don't know where I am.
So I'm telling you, you are in Mount Sinai. Zai asked me to give a talk which would have the flavor of translational medicine more than the basic research behind our work. And I will start with some known facts, definitely for many of you in the audience, about restenosis. 10 to 40% restenosis 6 months following angioplasty. Why 10 to 40? I can put here 5 to 25. I can put a figure of 30 to whatever. Depends who you ask, depends what you read, depends what you believe, etc., etc. The numbers are crazy in this field. And the stent that was introduced into the coronary arteries after the partial failure of balloon angioplasty was mainly for supporting the acute elastic recoil. And we got some less restenotic patients with this kind of development. And this is a very old slide back from the work that I've done with Eric Topol at the 90s about the possible mechanism of restenosis regardless if it's balloon angioplasty or it is derived from the stent deployment. And it was mentioned back at that time that we are talking about inflammatory arm, but there are also other arms, and the main result is smooth muscle cells proliferating, migrating outside the neurointima. So there was a change of paradigm, vascular injury that causes recoil, well, that was avoided by stents. Thrombosis, on the other hand, also is not the cause because the people are heavily treated with anticoagulants and new one and so on. So the inflammatory response is important, chemotaxis, activation of monocytes, other white blood cells, and so on. Our interest in this study was not translational one, and it was not that we would like to find a new drug for restenosis. Our interest in our group was that for finding a new drug, we worked on coating stents, and we worked on drug-eluting stents, like the dexamethasone one that we have now in the market, such as that. Our interest was to find the mechanism for restenosis, and it is known today that the healing wound response, proliferation of smooth muscle cells, this is the hallmark of restenosis, and it's the acceptable pathology. These are the first drug-eluting stents, the Cypher and the Taxus. The Cypher is not in the market anymore because from $2.4, I think, billion a year 4 or 5 years ago, they are now can sell only 700 million, and it doesn't worthwhile to produce it. The Taxol, for example, that has paclitaxel in it, by the way, just to mention one problem of drug-eluting stents, 30% of the drug stays there forever. Because no one has found how much is released after that, but it's known, and those who are familiar with the Monte Carlo assimilations of Rob Langerlab, if you have a matrix and drug is dispersed in it, some of it will not find its way out, never. This is the market, for example. More than 1.5 million coronary stents are used in the USA annually. It's a huge market. Most of them, by the way, in the USA are drug-eluting stents. I just try to summarize in one slide the various types that are there for drug-eluting stents. So there are drug-eluting stents that the drug is just on the surface, in a polymer, double-layered polymer, matrix polymer, depot polymers, double-coat polymers, no polymer in the stent, just grooves inside the stent. Most recent developments are those that are creating an environment which attracts endothelial cells, bioresorbable polymer, and bioresorbable stents. And I will show you just in few slides what are the developments in this area. The problem. One problem I have mentioned. Drug in some stents, drug-eluting stent stays there forever. Major issue is endothelialization of the metal-coated polymer stent. Bare metal stents are behaving from the point of biocompatibility very nice. When you have a polymer, it's complicated issue. Shown here in a nice picture, the Zions, which is considered one of the best stents today. How nice is the endothelialization there, and compare it to the Cypher, Taxus, and Endeavor. And here is in the higher magnification. And this researcher and Vermani in another slide shown here from the work of Vermani. It's important to have good endothelialization of the stent. This brings me to the idea that I will talk about my work in a minute, which are the endothelialization. When the injured artery, whether it's from a balloon or from a stent, is endothelialized back in a certain amount of time, you pacify the inflammatory response. And it is known to be very important in drug-eluting stents. So there are three generations, the bare metal stents. They are implanted today in numerous patients, millions all over the world, and some of them are having rate of restenosis, or how it's called, TLR, transluminal revascularization, that it is about 10%, and it's considered very good numbers. Some of them are performing similarly to drug-eluting stents. Drug-eluting stents, major issue, thrombosis. Few years ago, people were thinking it's 3%. We know today that it's only 1% after 1 year or more. It's an issue because it causes myocardial infarction and other serious problems due to thrombosis. And the new generation, improvement over drug-eluting stents that we should see, but this is the promise as per the initial studies, that we will have not only absorbable polymer, but absorbable stents. This is the summary in numbers if you would like to know, but we will continue. This is Jerusalem. I picked this picture because of it's rare. It's rare to have such cloudy days in Jerusalem, and I'm comparing my 3 days here. I think that I enjoy the sunny skies. Monocytes are attaching to polymers. This is a known. Here I am moving to my work, and it's a known feature for many, many years. Inflammatory response is also a very known issue, and it was associated back at the late 80s when only balloons were used, that people have said, well, you have an inflammatory response. This is one of the causes of restenosis. And we were looking in our lab how we can define which is the trigger cells, who is the culprit, who is the major cell that causes restenosis. And there were several papers at that time. For example, in 1996 there was a paper showing that intima thickness correlates with macrophages in the vessel. Also, there was the paper by Moreno in 1996 that macrophages, number of them, correlates very well with late lumen loss. And everyone knew something which is quite similar to cancer, that it's inflammatory associated, that first you have polymorphonuclear cells, after that you have surface activated macrophages, and then you have tissue infiltrating macrophages. We wanted to know if I will block one of the cells of the PMN, of the polymorphonuclear cells, what will happen in restenosis? And by that, I might reveal the mechanism of restenosis. That was the aim of the study. So our first target was the monocyte / macrophages, if it's in the tissue. And it came out to us that at the late 90s, 1998, there was a conference working on bisphosphonates. The bisphosphonates are drugs that are used especially in osteoporosis. They are blocking the osteoporotic cascade, and there are several drugs of the bisphosphonate family. At that time, people were looking, and it's used clinically over the world in millions of patients. At that time, the researchers were looking what is the mechanism of bisphosphonates. And I was an old bisphosphonate worker. I worked with bisphosphonate since my postdoc. And bisphosphonates are absorbed very nicely to the bone, but what is the intracellular mechanism? And since it was very difficult to grow osteoclasts in cell culture, researchers used macrophages as first cousin cells of the osteoclast to learn about the bisphosphonates. So here is the first and a half generation of the bisphosphonate, where you have a halogen on the geminal carbon. Here is the third generation. All of them are amino groups, and there are several other derivatives. They are more active, the second generation, and the bisphosphonates are not absorbed from the GI tract because they cannot cross the GI mucosa cells due to high hydrophilicity and being charged. If you inject bisphosphonates, 30 to 40% goes to the skeleton, and the other 60 to 70% is eliminated. The less than 1% which is absorbed via the oral administration per os is good enough for having very good results in osteoporosis. And today we have bisphosphonates which are taken daily. We have a tablet which is taken once weekly. We have an injection which is taken once monthly, half yearly, or even annually, depending on the type of the bisphosphonate and its activity, because it accumulates in the bone. So, how to inhibit macrophages? I didn't know how to inhibit neutrophils, but we were thinking that we can inhibit macrophages or monocytes, and look what happens with stenosis. So the bisphosphonates do not cross cells, but the mechanism, as I've said back at the 1998, was revealed as being intracellular mechanism. It is not just toxification of the hydroxyapatite that prevents further dissolution, but it's an internal mechanism, and they interfere with the mevalonate pathway. So this simple cartoon, it is back from 1999. And you can see here that the osteoclast, when they are chewing the bone, if prior to that the bisphosphonate is absorbed to the hydroxyapatite, due to the bisphosphonate's moiety that I have high affinity to the bone, like a Trojan horse inside the osteoclast, they are killing the cell, because rather direct penetration of the bisphosphonate to the osteoclast will be only dismal, because bisphosphonate doesn't cross efficiently cells. This is the mechanism. If so, what we can do is negatively charge nanoparticles that will be avidly uptaken by monocytes in circulation. The larger, the better. No question about it that if I will have larger particles, I will have more monocytes swallowing, phagocytizing our delivery system. I will put a bisphosphonate inside the delivery system. That could be a liposome vesicle, lipoid base, or it could be PLGA. I cannot inject it as is because it will go or to the bone or to the drain or will be eliminated. The only way to get to the monocyte is to give him a good meal as he likes, which are large particles and charged. We have done a lot of work, what is better, positively charged or negatively charged. Positively charged has more affinity to monocytes, but it's more toxic. So we stick to negatively charged. Size. Microns are much better than nanometer size, but we want to sterilize it, and we would like not to have complement activation. We don't want to have other side effects, like thrombosis and so on. So we stick to nano size, and the best size that we know, it's about 80 to 100 nanometer size of the vesicles. It should be negatively charged, of course, and shown here are, on the top are the liposomes and the polymeric PLGA nanoparticles. We have decided to go further to clinical studies, etc., with liposomes and not with the polymeric nanoparticles, because until today, there is not even one product which is approved by the FDA of PLGA-based nanoparticles injected IV or intra-arterial. You have liposomes, and by the way, the famous first nanomedicine was made of liposomes, and was invented in my faculty by my colleagues and friend, Chezi Bernholz and Alberto Gabizon, who invented the doxil, which is long circulating liposomes of doxorubicin. But we were on the opposite direction of Mulder and of Gabizon, namely, I don't want long circulating, I don't want pegylated liposomes. We know to prepare them, we are doing it for other purposes, this is not the issue. We want the opposite. We want simple liposome, conventional so-called, that will be avidly uptaken by the monocytes and will deplete them because you have a bisphosphonate in them. So how is the mechanism? Free bisphosphonate doesn't penetrate any cells and not the macrophage. By the way, I don't know, this is a real macrophage that was, the picture was taken in our microscope. It's a real macrophage, and probably it was St. Patrick's Day, so they put it in green, I don't know, and I couldn't take out the green color. So free bisphosphonate cannot cross cell membrane. But if I put the bisphosphonate, I am embedding it, encapsulating it in a delivery system, a particulated dosage form, should be particulated, and it should be injected IV or intra-arterial, and it can work also if you injected IP and several other methods, but never will work if you give it orally, of course. They are phagocytized, and in the lysosomes they will be degraded, and depending on the type of the bisphosphonate, there are different intracellular mechanisms, whether it's non-hydrolyzable ATP or the mevalonate pathway, but it inhibits the cell. Some of the bisphosphonates are doing it by necrosis, some by apoptosis, but you deplete the bisphosphonates. So we have done our studies on macrophage depletion, and we have seen that it's uptaken very nicely by monocytes and by macrophages in culture. The nice thing about our drug delivery is that macrophages are depleted or inhibited very nicely by liposomal bisphosphonates. But endothelial cells are not affected, which is great, which means that if I will give my drug to a patient, he will be able, for a certain period of time, to grow and to new endothelial cells in his lumen in the artery and pacifying the inflammatory response. Smooth muscle cells are also not affected dose dependent, depending on the dose of course, but in normal doses they are not affected, which means that inhibiting smooth muscle cells, which are proliferating in the artery, is not a direct effect, it's an indirect effect on the smooth muscle cells. And here you can see that in animals, we have done it in mice, in rats, in rabbits, and you can see that monocytes are depleted, and it's a transient partial depletion for 3 to 5 days, sometimes up to 7 days. In our first studies, we have done 2 injections or more, one before angioplasty, one during, one after, and so on. But then we found out that one single injection at the time of angioplasty is good enough to reduce the number of monocytes in the blood, depending on the dose, up to 80% or 40 or 30%. And they are coming back after 3 to 5 days. In this period of time, I'm allowing the artery to heal back by growing endothelial cells on its surface. And here is how we prove the mechanism, one of the proofs of the mechanism. Here you have native arteries of the rat. This is the lumen. The blood flows through the wall. If I'm doing an injury in our rat model, a balloon injury in the rat model, and I am injecting the rat with empty liposomes containing a fluorescent marker, you can see very nicely that after a short period of time, the fluorescent marker is inside the segments of the artery, even up to the adventitia. But if you inject the same rat with fluorescent liposomes containing also the bisphosphonate, you don't see anything in the arterial wall similar to the basal or native levels, which means that you killed the carrier. If you killed the carrier, the liposomes will not arrive to the injured artery. We have done it in the rat model, and you see the restenosis in the rat model, highly significant, nice reduction of the neointima. We have done it in hypocholesterolemia rabbits. You can see very nicely the form cells here that are developing in this model. Again, highly significant inhibition of restenosis. And lastly also, in stented animals, again, highly significant inhibition of restenosis. We also have done a lot of other studies which I'm not going to get into because I would like to describe a little bit about the clinical studies. So the mechanism is summarized here: blood monocytes, arterial macrophages by RAM11, everything is reduced. Arterial smooth muscle cells are reduced by an indirect effect, not a direct effect of the bisphosphonate on smooth muscle cell, because it doesn't arrive to the artery. Our drug delivery works in the systemic circulation, and we are those who are considering restenosis as a systemic disease and not only a local disease. It's a local manifestation of the disease, but look on the systemic manifestation of the inflammatory response. But smooth muscle cells are less proliferating in the artery because they are less triggered by the monocytes, which are not extravaganting or entering now inside the artery. So these were the preclinical interim conclusion. Inflammation is a fundamental process in restenosis. Biological targeting we are talking about, and effective in multiple animal models, partial and transient depletion of systemic macrophages, and we don't have overt infection. We didn't have side effects in normal doses up to actually quite a high dose, and the reason is that you have other innate immunity system cells that can combat it, and we are working only for 5 days. If there are other models of pathologies, you can re-inject and so on, but in the stenosis case, since it's an acute injury, one injection does the job. The first clinical trial, the first in a human, was done in bioaustralasia, and as Zai asked me, a company, Medinol, who is manufacturing stents, licensed the technology from the Hebrew University. They invested about $25 million in establishing a biotech company in Israel, and they are manufacturing the drug delivery from scratch in Israel. They are also FDA, GMP fully approved, and got the permits for doing clinical trials all over the world. Now, the first study was for safety, and it was done in New Zealand and Australia. We gave 3 dosages. The first one, high dose, 0.5 mg per kg. Group 2 was mid dose, and group 3 was low dose. Of course, these dosages were selected as per the animal studies that we have done before. And we got a surprise. The surprise was that if you look on the safety, everything was fine, no problem whatsoever. If you look of instant restenosis, we don't have a control because it was only stented patients. It worked very fine. But we got flu-like syndromes. And flu-like syndromes is nothing if it disappears after 1 day, as happened in these cases, even not with mild anti-fever drugs or paracetamol, aspirin, etc. Nothing was required. But not for the guys who are dealing with cardiology. They don't want to replace drug-eluting stent with a drug that causes mild fever for 1 day. So we had more to reduce, and by the way, till today we don't know exactly what is the reason to the mild fever or flu-like syndrome, because liposomal drug delivery systems are causing flu-like syndromes. Bisphosphonate injection is known to cause flu-like syndromes, and maybe the combination of our delivery inhibiting or depleting to a certain extent monocyte, this is causing the flu-like syndromes. But nevertheless, we got it. So we planned the phase 1 with lower doses as such that will not cause any kind of flu-like syndrome. And the phase 1 was done in Ireland, and the doses was randomized, double-blind, 0.15, 0.05, up to 0.005 milligrams. We are talking here about, and from a pharmaceutical point of view, we are talking here about homeopathy doses. It's a very, very low dose of the drug. But we got the pharmacodynamic response, namely if we look on the level of monocytes, we got the known depletion that we expect after 36 to 48 hours in the patient. And this is, for example, a patient who got 0.5 mg, not per kilo, 0.5 mg as a single dose. So actually, if you look on phase 0 about the pharmacodynamic aspect, you can see that if we look on the known clinical effect that monocytes are rising after angioplasty, we can reduce it even below the basal levels. And if you look on the phase 1 study, you can see that there is a significant reduction of monocytes. So we have a pharmacodynamic effect. So looking on the data, summarizing it, and this will help to see how a clinical study is evolving and how you continue. So the dose at the beginning was 50 or 5 or 0.5, and this is based on 100 kg body weight. But from then on, we stopped looking on that, but we said, okay, one patient will get 0.05, the other patients will get 0.005, and the other ones will get 0.00305 milligrams of the drug. It's a very, very low dose, and nevertheless, by the way, we have a pharmacodynamic effect in all of them. So we have to avoid the region here that are associated with the side effects, which are flu-like syndromes, and according to the color is the severity. The most severe one are those with the 0.15 and 0.1 mg total dose, which are nausea and headache, but the cardiologist doesn't want it to have. So we had to select a very low dose for the phase 3 out of these results. So we have done the phase 2A study, which is called the BLAST. Cardiologists like to give these names, which is BioWest liposomal alendronate with stenting study. BioWest is the spin-off company of Medinode that bought this technology. And this study was done on 225 patients in Israel. 2 dosages were selected, 1 and 10 micrograms. And we had the results a few months ago that it was published in American Heart Journal. The full study group, no side effects, but no effect. No statistical effect on the full study group. But when we look on the diabetic subgroup, and by the way, this was pre-planned to the study. It's not that after the study you took the diabetic. You can't do it. At the beginning of the study, we planned it to look on diabetic groups, which are known to suffer from drug-eluting stents, which are not working. They are stenotic highly.
Sorry, these patients have multi-vessel disease or single-vessel disease, diabetic?
In some cases have multi-vessel disease, but even a diabetic patient who is having one vessel disease, the drug-eluting stents are not working very well in these patients, and they are suffering for a very high rate of stenosis and from other problems due to that. So this was barely significant, but the number of diabetic patients was not, there was not enough power in the number of diabetic patients to prove that it's significant in this patient. It was just part of the full 225 years. But if you look on the inflammatory subgroup, and what is the inflammatory subgroups? We took the patients and took the median of the number of monocytes and divided all of the 225 to 2 groups: high monocytes, low monocytes. Above the median, below the median. By the way, the high monocytes group are completely healthy patients that just need angioplasty. According to the hospital levels and laboratory levels, they don't suffer from any kind of disease that will cause them to have high monocytes in the blood. It is just happening that when you are doing the blood test at day 0, they have higher monocytes level than the others. And looking on this patient, we got a significant results of reducing restenosis.
Do you have C-reactive protein in these patients?
Yes.
Okay. And were you able to subdivide or not?
No, this we didn't do. Now, this supports the idea that if you look on the patients, on the skewed Gaussian of the distribution map, you see that both treated groups are not normally distributed. They are not log normal or normal distribution. Only the placebo group are normal, which means that we have responders and we have non-responders. This could be one possibility, but definitely it's indicating that the treatment group does something to these patients, and could be, there are thoughts about personal medicine or something like that, but nevertheless, there is some kind of a mechanistic approach in our treatment that can be seen in these skewed distribution levels. So if I will summarize the clinical trials, the first in human study, phase 0, was proved to be safe. Phase 1, safe, dose-dependent, mild side effect, flu-like syndrome, but nevertheless pharmacodynamic effect, they are effective. Phase 2A, the last one, effective in pro-inflammatory patients. Pro-inflammatory means that they are above the median of normal patients, that no one needed any further checkout or clinical manifestation of having high monocytes. And phase 2B should be started in few months. It's expected soon in diabetic patients. Half of them will be randomized to get drug-eluting stents, and the other half probably will get drug-eluting stents plus the medicine. Of course, that doing another study, like with a higher number of patients or higher dose, could elicit possible results also in the full population. But right now, the phase 2B is planned in diabetic patients. and this is the rationale that I've just mentioned. Inflammation is the hallmark of restenosis. Monocytes are the key mediators of inflammation. And we are talking about biological targeting, and we are talking about systemic inflammation with local manifestations in the artery. This is the way that we are looking on restenosis. I just want to give, 3 minutes just to look on, because Narendorf was mentioned before several times, and his great work about subpopulation of monocytes. And we have done the subpopulation of monocytes also in rats, because and developed a method, a FACS analysis, to analyze subpopulation of monocytes in rats, which is very difficult, because the restenosis model in the rat is much more easier than doing it in mice. So we looked, for example, about 2 dosages of liposomal alendronate, 3 mg or 10 mg per kg, neointima plamidia in restenosis, and it's working for 14 days or 30 days. But after 30 days, the 3 mg per kg is not significant anymore, and you have a reduction of monocytes as expected, dose-dependent. There is a more reduction with 10 milligram per kilogram compared to the 3. But we asked ourselves whether this reduction or difference in reduction is enough to explain the different response to restenosis after a long period of time. So we have done subpopulation of monocytes, and we found that there is really a difference if you look on the subpopulation of monocytes, whether they are classical monocytes or non-classical monocytes, or what's so-called in some places the pro-inflammatory and the anti-inflammatory. And we start to find differences in the response. We don't know yet if this is significant in restenosis, but definitely in the MI model, and by the way, this is the famous paper by Anderson, Narendorf, and Bob Langer, my mentor, on therapeutic siRNA silencing in inflammatory monocytes. But we have a formulation, we call it MPT liposomes, and we are trying to show that if you are injecting this formulation at the right time of the B phases of MI, because if you inject it on day 0, it will have a devastating effect. If you inject liposomal alendronate, it will not work, or will cause even worse results. But if you are injecting this drug, the new formulation, in this case, you on 3 or 5 days, you can find that the ejection flow of the left ventricle is functioning much better, which means that we would like to be in a situation of, instead treating animals, and after that human beings, with non-discriminative depletion of monocytes, we would like now to be in a position to modulate the ratio between classical and non-classical monocytes. We are not sure that it's related to restenosis, because in restenosis, it's completely different than MI. In restenosis, you have an acute injury at the time, you are giving your drug, 3-5 days freedom of inflammatory monocytes, and after that you are free from restenosis for several years later on. So these are the conclusions. I think that I've mentioned all of them by heart. I would acknowledge my collaborators. Chaim Dannenberg, the cardiologist from Hadassah, who is working with me. Elazar Edelman helped us with the stented rabbits and the clinical study. And of course, delivery is everything. You should be aware of it.
Great, thank you.
Excellent. So this is a very exciting work on a very important problem, very topical in terms of the monocyte, the macrophage, and their modulation. Do you have any questions? So I have a question to ask you, maybe a little bit to understand better. There have been some interest in the evaluation of, with imaging techniques, the use of a positron emission tomography, not only with fluorodeoxyglucose, but with sodium fluoride, which basically is an image of the bone. And what they found in some of the vascular studies in patients with cardiovascular disease, either at the valve level with the calcified valves, or in vasculature such as the coronary artery, there's paper coming out in the Lancet about this, is that the sodium fluoride is giving us a signature that is beyond what we see on FDG, and not really colocalized with the calcification as we know at the hydroxyapatite. And I know the aspect of biphosphate and how biphosphate interacts and modulates maybe some of these lesions. It would be interesting maybe to consider in a small study, and maybe you've already thought about that, to actually do some imaging to try to see the effect, not beyond what you can measure by FDG, but also on sodium fluoride. Can you maybe comment on that? Or?
Yeah, because the bisphosphonates.
Yeah.
The bisphosphonate can actually intoxicate hydroxyapatite. So we can try to give a bisphosphonate, and then you might see that the sodium fluoride is less absorbed to the hydroxyapatite, and by that maneuver the uptake of the sodium fluoride. It's interesting. Yeah. Okay.
Okay, so great. So I guess people are anxious to have the lunch. We will break for lunch for about an hour, which will be outside, and come back exactly, please, at 1 o'clock. We have also a full and exciting program. Thank you very much.